I just want to start off reiterating some national available emergency help, just in case you are having an emergency. You can call 911 or call or text the National Suicide Prevention Lifeline. In the US. If you're in a different country, I know that academia is a worldwide endeavor, and a lot of people are from a lot of places and might be able to work from many places. So if you are in another country, you can go to this link as well. I do want to emphasize that while I am a mental health researcher, I'm not a mental health provider. No one at Dragonfly Mental Health is providing medical advice, and this information that we're presenting today does not substitute for speaking to medical professionals about your own personal experiences and needs. So the outline of the talk today, and I really do want to get to questions and answers, so I'll go a little bit quickly, but hopefully everyone will be able to keep up, and I'm happy to rehash anything in the question and answer portion of this, this hour-long seminar. I'll start off by telling you a little bit more about me and Dragonfly Mental Health. Then I'll elucidate specifically what this talk is and what it's not. It's important to specify the difference. One of the things I'll introduce is the idea of the spectrum of mental health. This talk today, because we have limited time, will be focused on touching on a whole variety of mental illnesses. And mental health, as we'll discuss, it is a spectrum. Many things are interrelated. An individual can experience any point along the spectrum at various times and locations and throughout their lifetime or their day. So we we'll also touch a little bit within each of these about treatment, and I'll emphasize prevention as well. And at the very end, we will hopefully have quite a bit of time to have a group discussion where you can put your questions anonymously for Kelly who's going to be moderating those and reading them out loud without identifying who the question came from. So my name is Dr. Wendy Ingram. I have a PhD in molecular and cell biology from UC Berkeley. I finished in 2015. And I've been involved in research from biochemistry, molecules, all the way to populations for 17 years now. So from undergrad in a biochem lab to studying molecular and cell biology as a PhD student, and then training in psychiatric epidemiology at Johns Hopkins School of Public Health. And in addition to my research, I have over the years created a couple peer-led organizations to address mental health problems. I did this both at UC Berkeley with a number of colleagues and again at Johns Hopkins University. And both of these were due to personal losses of colleagues of mine to suicide and depression. So what has happened in the last year is that we've taken what I've learned from starting smaller grassroots projects at Berkeley and Hopkins to creating a global worldwide organization by academics for academics. And so we named this Dragonfly Mental Health. And we have three main modalities that we operate in. One is we have a collection, a consortium of academics that conduct research and are hoping to address the systemic issues, the really big issues that can't be addressed on a small community by community basis. We also are building a worldwide community of academics that care about and facilitate the support of one another through something called Dragonfly Cafe. And what this is one of the features of is our on-campus program. So we create cultural and climate changes directly within academic communities by improving mental health literacy, decreasing stigma, and increasing people's skills through workshops. And so we have, for the on-campus programs, we have this this idea of a wellness wheel, or 5 key domains of excellence in order to cultivate excellent mental health among academics and researchers such as yourselves. And we realize that this has to be customized for each community. A lot of the work before this talk was spent talking about the specific needs, the specific organizational structures about LB&L in order to customize things. And so we recognize that, we look at that, and we encourage, in addition to skills, literacy, and stigma, also creating departmental and peer networks of individuals to talk about and destigmatize mental health needs. So Dragonfly is a really phenomenal organization. In just a year, we've recruited over 100 volunteers from over 15 different countries. People are from all types of disciplines, from STEM to medicine to humanities. They're absolutely incredible to work with. So if anybody's interested in this and passionate, please visit us and let us know if you'd like to get involved. So what this talk is a brief, very brief mental health introduction. We're going to emphasize depression and anxiety and a few other things that are more common amongst academics, or something that's particularly important for us to think about, know about, and destigmatize and improve, demystify. So this is meant to be, as was stated previously, the beginning of an ongoing conversation about mental health literacy, culture change, and response preparedness. It's not meant to be comprehensive. It's not a response training. Those are other things we offer, but this is not it. And it's definitely not everything you need to know in a nutshell. It really is scratching the surface, but from a scientist perspective, we're giving you that. And I am not including anything about my research. So if you're interested in that, reach out to me directly. So the mental health spectrum. People talk about mental health, or they could talk about mental illness, but really there's a broad array of states of your mental capacities and current situation. And so mental health is one end of that spectrum. Many people, basically it would be bizarre if you've never experienced stress. Stress is something that we experience, especially in higher education and in high pressure research institutions such as the lab. Distress is beyond just stress. Moving from being stressed in a moment back to a mentally healthy state is something that's arguably pretty easy. It won't take a lot of outside help or support, whereas distress is the next phase. It's where things are lasting a longer time. They're harder to get back to that mentally healthy state. Maybe you have to be a lot more cautious and careful about what's going on there. Might require seeing a psychologist in order to work on tools to, when you get distressed, to move back into a mentally healthy state. Disease is something beyond that. So I'll define that in the next slide, but that is beyond just distress. It's something where a mental disease or mental illness is at a stage where people are diagnosably struggling with a depression, maybe a major depressive episode, perhaps bipolar disorder, perhaps OCD, obsessive compulsive disorder, perhaps anxiety. These are diagnosable diseases that usually require medical or professional intervention in order to deal with, and that's fine. People with mental illnesses and diseases, though, are fully capable of being in a mentally healthy state, even if they have an ongoing chronic disease. And then finally, crisis. So if someone is acutely psychotic, if someone's having a panic attack, if someone is experiencing such severe depression that they're considering suicide, this is a crisis state. This is something that requires immediate response and immediate assistance. And our talk today is really going to focus on touching on a number of relevant diseases of the mental system. So what makes it a disease? The symptoms generally have to be consistent for more than a reasonable amount of time. So this seems like a very vague statement, but it does differ from depression to anxiety to PTSD. So all of the different things that you could struggle with or have a diagnosable disease with depends on the disease itself. And so the ballpark overview is that symptoms do have to be relatively consistent for more than a reasonable amount of time. And it doesn't have to be constant, but it does generally need to be more days than not. Usually it is longer than 2 weeks, but as anyone who struggled with depression or anxiety, it can last months. So another key point about diseases is that they must represent a significant change in the person's normal experience upon onset. So some people are cranky and that's just their personality. That doesn't mean that they're struggling with depression and irritability if they don't have the whole cluster of signs and symptoms, and they've kind of always been that way. Social, occupational, educational, or other important functioning is the final piece of what makes it a disease. If the functioning is negatively impacted by these changes, this is one of the key components of it being identified as a disease, diagnosably. So I want to say a few things about mental diseases in general, because there are some universal principles here. All of them are real, biologically and environmentally driven illnesses that can be episodic, chronic, or singular events that only last for a short period of time. They can be preventable and are ubiquitously highly treatable. It's a misconception, unfortunately, that's still held today that we don't have a good handle. We may not have a good approach to treating mental illnesses, but I can tell you as a researcher and as someone who works with clinicians in the mental health field, the amount of improvement in our understanding of the illnesses as well as how to treat them effectively has massively improved. So I assure you that they are preventable and highly treatable. Another piece that is why it's important for your employer, for example, to bring in someone like me to talk about mental health and improve mental health literacy is that it's critical to create a mentally healthy climate, that the culture is and access to care through community support is such an important piece of that. So it matters who you're surrounded with and what they think and what they know about mental health issues and diseases. So we're going to start with mood disorders and anxiety. Mood disorders are my specialty, so I'll speak a little, and they are the most common of diseases that people struggle with, so, mental diseases that they struggle with. So I'll spend a little bit more time on this and move a little bit more quickly through the other slides. So depression and bipolar disorder and anxiety, which is also highly comorbid with these two diseases, can exist alone. And what we do know, since we did, I mentioned that I was motivated to start some peer network groups because of suicides that I experienced in my community. The reason why we're not focusing on suicide, we're focusing on the spectrum of mental illnesses, is that suicide, the vast majority of suicides are due to, about 80 to 90% of them are due to an underlying mood disorder, most commonly depression, which is the most common mental health disorder that people struggle with. So 16% of people worldwide will experience a major depressive episode at some point during their lifetime. And in the general population on a day-to-day, so if you say you survey generally the community, you would expect that about 6.7% of the general population meets criteria for a current depression or bipolar disorder, and about 6% of people experience on a current diagnosable anxiety disorders. But what we found in surveys and research, these are numbers specifically from Evans et al. In 2018, which was published in Nature Biotechnology. They found that 39% of students met diagnostic criteria on a validated screener for depression, not mild depression, moderate to severe depression. And 41% of participants, not over 50%, 41% met criteria for moderately severe to severe anxiety. So the best way to prevent suicide is to treat the underlying mood disorder. And the two things that if you do know someone or you are having issues right now, struggling with ideas about harming yourself, restricting means and avoiding substance use are the two most critical pieces to do immediately. And getting help is the next. So symptoms of mood disorders are not just mood. Mood and anxiety. They affect the mood. You can be irritable. You can be depressed and sad. You can actually feel nothing at all. And that's something that a lot of people don't know and don't realize. It can affect the body and your behavior. So you can be gaining weight or losing weight. You can be having like anxiety type symptoms will have a lot of physiological effects, like your heart starting to race, you feeling like you are having a heart attack maybe even. Also for the body, you can experience pain and lethargy in your body. You can also have a lot of behavior things that change too, more impulsive behavior, or where your speech is slowed, or various things like that. And then the third piece that people, kind of tend to know, but often dismiss is the thought disorder. So depression, bipolar disorder, and anxiety can all cause racing worried thoughts. It can cause your thoughts, like I said, to be slow, which then is reflected in your speech. You can struggle to find more the words that you're looking for, the names that that are normally on the tip of your tongue. And then suicide and suicidal ideation itself is a thought disorder. So believing that the world would be better off without you, like believing that strongly, having thoughts of that is something that is usually not at all reflected by the people around you who care for you and do want you here. And so it is a thought disorder that does need to be addressed as soon as it starts happening. It is the best recommendation. The causes are myriad, actually. So there's quite a bit of genetic data about bipolar disorder. There's quite a bit of genetic data about depression predisposition and anxiety predisposition, but we do have identified that the immune system and endocrine dysfunction can cause depressive and anxiety symptoms. You can have nutrition, sleep, or exercise deficiencies and cause the same symptoms as depression. And as many people know who may be familiar with the treatments for depression and anxiety, SSRIs or selective serotonin reuptake inhibitors, do implicate the serotonergic pathways. And then I do want to emphasize, though, that a lot of depression and anxiety is influenced by trauma, is influenced by traumatic events and stress. And extreme chronic stress or unpredictable stress, which sounds a lot like grad school to me. So I do want to, I'm going to emphasize on each of these points and each of these diseases, though, that there are successful academics and researchers out there that struggle with these conditions. And so I do want to make sure that people know that struggling from these things absolutely does not preclude you from being a success in the field of science and research. So Dr. Kay Redfield Jamison wrote a phenomenal book on Unquiet Mind about her own bipolar disorder. She is at Johns Hopkins and she is the world's expert on bipolar disorder. So burnout is something that a lot of people kind of conflate with depression. So I did want to go through that and explain the differences between the symptoms and the causes. So the symptoms of burnout is that, generally speaking, burnout is only work related. It can involve the fact that outside stresses or family stresses are contributing to it, but burnout is more exclusively work related. So the symptoms are emotional or physical exhaustion, reduced resilience and adaptability, maybe increased cynicism about work and about your colleagues, reduced performance, and way reduced concentration. And the causes are chronic stress relating to work or, like I said, other ongoing activities. Usually it has something to do with a lack of control. So it can also involve bullying or toxic work environments or relationships, especially with mentors or with superiors. And is usually caused also by a lack of work-life balance. So there's been a lot of research, especially in the medical field, about burnout already. And what it turns out helps is taking breaks or vacation. So negotiating better hours or accommodations or improving your communication strategy with the people and the folks that you're working with definitely improves and reduces burnout. Seeking support and building better relationships at work, things like mindfulness, sleep, and exercise, usually people experience once they really commit to doing those things, they improve dramatically. In contrast, a lot of forms of depression, those are not sufficient to treat it. So that is when, if those don't work, time to start talking to a psychologist or your medical professional about your situation and what you might need to do to address that. So psychosis is something that's not necessarily the most common thing, but it's often one of the most disruptive, both for the individual as well as the people they're working with or that care about them. So the symptoms are that you become disconnected from reality. Someone who's experiencing psychotic symptoms may have very bizarre behavior. They're doing a lot of things that they wouldn't normally do, that maybe they're dressing dramatically differently. They may develop delusions, the most common of which are persecutory, so thinking that other people are trying to steal their work, thinking that people are out to get them or breaking into their home, or it can also be of contamination. So a lot of people with delusion who develop psychosis will develop a delusion about maybe, they're sick with something, like there's black mold everywhere, or there's parasites under their skin that no one else can see and doctors won't listen to them. Another thing that can be related to maybe thinking you have parasites in your skin are hallucinations. And hallucinations can be visual, they can be sensory. So if you feel things that aren't really there, that can be something that people experience and is a hallucination. And they're most often auditory, so they might hear voices or something. A lot of folks who are experiencing psychosis also engage in chaotic and incoherent speech, and or because we're so distant, you might experience it through their writing, through emails, through writing manuscripts, reports, things like that. So the causes are that actually for schizophrenia, the most common psychotic disorder, which about 1% of the population worldwide will develop, is about 50% genetic. So this is from twin studies. And so we do know by that then identical twins, if one develops schizophrenia, the other one has a 50-50 chance. That means 50% of it really is from environmental triggers as well. And it can be a myriad of things. We don't have a good handle on what exactly those things are. You also can develop psychotic symptoms from extreme sleep disturbance. If you haven't slept for days, you've developed insomnia, psychotic symptoms can come from it. Substance abuse is very, very commonly inducing psychosis. And even when someone's withdrawing from alcohol or from a particular kind of substance that they may have been abusing or using, they can experience psychosis too. It can also accompany other disorders like bipolar mania or borderline personality disorder. And usually these are termed as psychotic features of a different disorder. So what helps is very, very clearly medication. So antipsychotics, psychodynamic therapy, and dialectical behavioral therapy are three ways in which you can get really, really effective care, get your mental disease or mental illness under control, and return to a state of being mentally healthy. And psychosis, really, I want to emphasize, is not the end of a career. A lot of people are afraid that if they are experiencing these things, that they shouldn't tell people because they'll get fired, they'll get, ostracized, they'll be termed locked up. So there's another professor in Southern California, Professor Ellen Sachs, who wrote a book, The Center Cannot Hold, and she's a very successful law professor there. So that is an excellent book to see about that. So as many of you noticed and indicated correctly in the pre-talk survey, substance use is highly comorbid with other mental illnesses, but it is a mental illness on its own. So about 20 million Americans a year qualify for having a substance use disorder, yet only 10% on a yearly basis will seek treatment, which is really tragic because it is treatable, and people's lives will get much, much better if they seek treatment. So the symptoms of substance use disorder is often, and it'll depend on the individual, but it's often termed as if you have to use a substance daily, if you're binging on the substance, if you experience blackouts or memory loss, if you lie about your use to friends, family members, coworkers, if you experience cravings or your using is impacting your work, your relationships, your friendships, or your mental and or physical health. So alcohol abuse can actually lead to depression. The use of opiates, prescription opiates, will also lead to, especially at high levels, will also lead to depression as well at pretty alarming rates. So disentangling these kinds of comorbidities, or the fact that they're leading into each other, does one lead to the other? Yes. And which one's which? Both. So the causes really, as I mentioned, are estimated to be about 40 to 60% genetic. So it's not someone's fault, it's not weakness. It is something that exists in the biology, the underlying biology, and can often be triggered or develop because someone's using substances for coping behavior, or let's people say self-medication. A lot of people experience social pressure depending on who they're hanging out with and what the culture is. Drinking cultures at conferences seem to be cited quite frequently among people in these surveys who are academics as being problematic for them if they're struggling with something like alcohol abuse. And really easy access to things like cannabis and alcohol can be problematic for folks who struggle with it. And it can lead to dependence, which is linked to the other mental diseases. So what helps is detoxification programs, support groups in order to maintain sobriety, and individual or group counseling, and especially peer support and understanding. The treatment of the co-occurring mental health disorder is going to be critical if you are going to treat someone who has what's called a dual diagnosis, a substance abuse issue and a mental health condition. So autism spectrum disorder is an interesting thing because it does tend to be a little more common among those who are seeking especially STEM-related PhDs than the general population, high functioning autism. But I do want to emphasize that it's a very, very complex developmental condition. And folks who end up in higher education and in research and science will often involves persistent challenges in social interaction, speech and nonverbal communication, and restricted or repetitive behaviors. Again, the causes are not particularly well known here, but we do have estimates that about a quarter are due to specific genetic novel mutations, but about 3/4 may have multigenic risk or just causes are unknown. And there's a lot of medications that are used to treat other things that come up with experiencing autism spectrum disorder that are focused on treating other things such as depression, ADHD, or OCD. Psychotherapy is highly helpful. Occupational or educational therapy are helpful, and sensory integration therapy is very good. There's a very famous professor, Temple Grandin, who Oliver Sacks famously wrote a book about, or a story about, an anthropologist on Mars. And so she's definitely someone to look into as an inspiration for being able to do very, very well and innovative work. So obsessive compulsive disorder is the last thing that I'll mention. And we'll go through the symptoms. So the strong urge to perform certain routines or rituals are what the compulsions are, and unwanted repetitive thoughts or intrusive fears are what the obsessions are. And so people can be really debilitated by this condition because they spend up to hours a day sometimes performing these physical or mental rituals. And it can also lead to avoidance of triggers and people because they're worried people will notice that what they're doing or that they're not engaged. So the causes, again, are a little, less known, but they definitely have some genetic leads. We have seen that trauma and as well as brain structural differences might be physical causes of this as well. And while OCD is only found to be about 1% of the general population, in academia, some studies have found that about 3.5% of folks in STEM fields are diagnosable for OCD. So what helps with OCD are cognitive behavioral therapy, exposure and response prevention, and medication as well. And I did discover a wonderful person named Dr. Nadine Muller, who has a website where she speaks about her own experience of OCD. So the things I really want to drill home for you is that mental disease is highly treatable. About 80% of major depressive episodes respond to standard treatment. These are similar, if not higher numbers for other diseases that I mentioned. One of the key things that we've found from epidemiological and intervention research is that awareness, early identification, and early treatment are critical for people getting help and getting better. So the average person waits 6 to 8 years to seek treatment. Let that sink in. So the problem with this, the major problem, is that the entire time that they're experiencing these symptoms from the onset, they're functioning at a lower level. They're struggling, they're having a hard time. It's inhibiting their ability to do well and be happy and experience health. And it's also usually getting worse. So untreated mental illnesses often result in other comorbid disorders, which complicates the recovery. So this also will delay treatment response, even when you do start seeking treatment. So the earlier you can get in and address these things, the better. The other thing that we've found really quite clearly is that community support and encouragement is hugely important and impactful for seeking care and sustaining treatment engagement. So this is why we're doing things like this and bringing this to communities that can improve the support and openness with each other about these things. So as mentioned previously, graduate students have been found to have 8 times higher rates of severe depression and anxiety than the general population at the same age. And these are things that this is a very serious issue. And once you've developed something like depression and had one episode, your likelihood of developing another is much, much higher. Your odds double or triple depending on how many episodes you've had. And another study, a few studies I wanted to emphasize are that those with higher IQ and education, educational attainment, report higher rates of mood disorders and are less likely to seek treatment. So I do want to finish with one thing that I like to emphasize, which is that everyone who goes through grad school, everyone who gets their PhD is undergoing similar types of stress. But if you belong to a different group of people or have a different identity than maybe the majority, you experience different things. And these are called minority stresses. And so if you're someone who identifies as a woman, you may experience sexual harassment and violence. If you're a first generation student or highly educated individual in your family to go to college, you can experience much more economic challenges and discrimination. People of color experience racism and discrimination. International students or employees who are coming from different cultures may have issues with cultural adjustment as well as language barriers. And folks from the LGBTQ community often experience marginalization and extreme homophobia. And so all of these together, especially if someone comes from, intersectional experiences and identities, it's often more than additive what this minority stress experience and impact is on them. So it's important to acknowledge that if you don't belong to one of these communities, they may be, someone who does may be experiencing things that you don't know about and wouldn't necessarily experience yourself. So a final little comparison I'd like to make before we start taking questions is that between elite athletes and academics. So Serena Williams is by far one of the most amazing athletes we've ever seen, and yet when she experienced something at the a tweak of her ankle at the US Open last year, she was immediately seen by professional care. There is prevention, there is immediate response, and it's even public. Athletes' instruments are their bodies, and so they treat them as such. Incredibly important, and the most important thing to protect and respond to and not overtax, even as they become incredibly talented and continue to achieve at the highest record-breaking levels. And what we see in academia is the opposite. Our minds, which are our instrument, when we're struggling, we tend to just keep doing the same thing. So I question that, and I ask you to think about that and question it as well. And I will end the talk there.